Good morning, everyone. I'm very pleased to welcome you all to Healthwatch Week, our virtual conference. And what better way to kick off our week of conversation than with this first keynote session on health equity in England. The inequity in the impact of COVID-19 has shone a light on the UK's long-standing health equity challenge. Health equity is therefore a theme that will run throughout this conference and Healthwatch's work beyond. I will also be chairing tomorrow's panel discussion, where we will be exploring the issues in more detail. So for today's session, we are fortunate enough to be hearing from two giants in the field of health equity. So Michael Marmot is the author of The Health Gap, The Challenge of an Unequal World, and Status Syndrome, How Your Place on the Social Gradient Directly Affects Your Health. He was chair of the Commission on the Social Determinants of Health, which was set up by the World Health Organization in 2005. And at the request of the British government, he conducted the Strategic Review of Health Inequalities in England post-2010, which published its report, Fair Society, Healthy Lives. This report was unequivocal in its description of the social gradients of health inequalities. Put simply, the lower one's social and economic status, the poorer one's health is likely to be. And its argument that traditionally government policies have focused resources only on some segments of society. The follow-up Marmot review, 10 years on, was released in February this year and argued that people can expect to spend more of their lives in poor health, that the health gap has grown between wealthy and deprived areas. Sean Linton has helped expose the poor care scandal at the Mid-Staffs NHS Foundation Trust, and he sat through most of the 139 days of evidence of the Francis inquiry and gave evidence. He is a strong believer in public interest journalism in the NHS and health, and has been a journalist on the Independent newspaper for the past year. His work is focused on reporting accurately and fairly on issues of patient safety, quality of care and regulation. He is a passionate advocate of the value of public interest journalism as a force for good, as evidenced by his current challenging pieces on the response to COVID-19. So it is an honour and a fantastic coup to have secured both Michael and Sean for this session. Michael will speak for 10 minutes on the subject of health inequalities, and he will then be interviewed by Sean for a further 20 to 25 minutes, after which we will open for questions. I'll ask you to put your questions in the Q&A box, not the chat box, and the button to the Q&A box is at the bottom of the screen in the middle. If you click on it, it will open. So I'm now going to hand over to Sir Michael. Oh, Michael, you're on mute. Still on mute, Michael. That's better.
Thank you. And it's a pleasure to talk to this important group. I will talk briefly about both my report, the 2020 report, and the pandemic, because I think they're linked. And as you said in the introduction, I've been arguing from the beginning that the pandemic exposes the inequalities in society and amplifies them. So remember, my 2020 report was published on the 25th of February this year, before the pandemic crashed upon us. We called it Health Equity in England, the Marmot Review 10 years on. And my simple summary was, we have lost a decade, and it shows. And this is what I mean. Life expectancy for women and for men, that's going back to 1980, had been increasing about 1 year every 4 years, and it slowed dramatically. the break in the curve happened 2010. The government was a bit sensitive about, my goodness, could it be anything we did that could have led to that slowdown? It's possible, as I'll show you in a moment. One question that got asked was, well, it's got to slow down sometime. We can't keep getting improvement in life expectancy forever. Maybe we've just reached peak life expectancy. No, that's not the case. This is the life expectancy improvement in weeks per year. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, all these countries. There's the UK. All those countries had more rapid improvement in life expectancy than we did. The only rich countries that had slower improvement than us were Iceland and the USA. So no, we had not reached peak life expectancy. And again, as you said in the introduction, is health inequalities are not confined to poor health for the poor. This is level of deprivation. The most deprived, the least deprived. It's a social gradient. The less the deprivation, the longer the life expectancy. The gap between the top decile and the bottom decile is 9.5 years for men, 7.7 years for women, and that's been increasing. The gradient has been getting steeper. And if we look at region, this is women. It's not too different for men. Let's look at the least deprived 10%. If you're in the least deprived 10%, it doesn't matter much which part of the country you live in. Life expectancy was improving a bit. If you're in the most deprived 10%, it matters enormously which part of the country you live in. Life expectancy was improving for women in London in the bottom 10% and declining almost everywhere else. And there's a huge regional spread. The more deprived you are, the bigger the disadvantage of living in the Northeast and the Northwest compared to London and the Southeast. Now remember, we had the most marked slowdown pre-pandemic and then the pandemic. If you look at excess deaths, so that's not COVID-19 deaths, it's how many deaths were there in 2020 compared with what you might have expected based on the previous 5 years. It's excess deaths. And England had higher excess deaths than Scotland, and England had higher excess deaths than any country in Europe. So pre-pandemic, we had the biggest slowdown. Post or during the pandemic, we fared worst. Maybe there's a link between how we managed as a society before the pandemic and how we managed during the pandemic. And part of my argument is that the health of a population tells us a great deal about how well that society is meeting the needs of its citizens. And inequalities in health tell us a great deal about inequalities in society. Here's the social gradient in all-cause mortality, that's the gray, and the blue is COVID-19. In other words, the causes of inequalities in COVID-19 are really rather similar to the causes of inequalities in health more generally, with this excess here at the most deprived end, which is arguably related to employment in frontline occupations and overcrowded multi-generational households. There's Scotland, the gradient for all causes, and the gradient for COVID-19, very similar. One of the things the pandemic has done is expose the ethnic inequalities. Look at women, the excess for Black, British, and then adjusting for deprivation and geography, most of that excess can be attributed to deprivation and where you live, and more than half in men. Bangladeshi and Pakistani, almost all of it in women, and most of it in men can be attributed to deprivation and geography. In my book, The Health Gap, The opening line was, why treat people and send them back to the conditions that made them sick? The health care system is vital, and we recognize that. But I'm focusing on the conditions that make people sick. And in my 2010 review, I had 6 domains of recommendations: give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to live on, it was number 4, healthy and sustainable places and communities, and taking a social determinants approach to prevention. What did the government that was elected in 2010 do? Well, they said, we want to roll back the state. They might have used slightly different words, but public sector expenditure in 2009-10 was 42% of gross domestic product, and that went down year on year till that 42% became 35%. And it was done in a most regressive way. This is council spending per person. Look at the grey, which is total local authority spending, by deprivation of area. In the least deprived 20%, council spending per person went down by 16%. And then the greater the deprivation, the bigger the reduction. So the reduction was 32% in the most deprived 20%. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could that account for worsening inequalities, slowdown in overall health improvement, and decline in health for the poorest women outside London? Yeah, I think it could. And let me look at just one measure, child poverty. We know that child poverty is vital for children getting the best start in life. Child poverty is defined as living in a household at 60% median income or less. Pre-housing, before housing costs, 18%. After housing costs, 27% of children in 2010-11, and that 27% went up to 30%. I noted that in Parliament, the Prime Minister said, oh, we've taken 400,000 children out of poverty. I thought, what? I'm just looking at my report. Child poverty went up. And he came back the following week and he doubled down. I thought if you lie to Parliament, you're supposed to apologize and come back and tell the truth. He doubled down on the lie. Child poverty went up. And as we think about emerging from the pandemic, what will society look like? This was 2019, pre-pandemic. The New Zealand Treasury, Ministry of Finance, said at the heart of government policy should be a well-being approach, which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. That is what I would like us to be thinking about as we plan for the future. Thank you.
Thank you very much, Michael. And for everybody who's read your reports, hearing it spelt out like that in detail just underlines the seriousness of the subject that we're discussing. I'm going to now hand over to Sean, who's going to interview you, Michael.
Thank you, Danielle. And Sir Michael, thank you very much for taking us through that comprehensive summary there of some of the issues that we're going to discuss. They've unleashed me upon you for about 20 minutes, I think, but I'll be a gentle interviewer, I promise. I'm hopefully encouraging the audience to submit their own questions as well. I'm sure they can do a better job than I can. So do take part and join in. So, Michael, I wondered if we could, first of all, take a step back a little bit and set the context for this, because you've been working in this field now for a long time, and I would be interested to know the efforts that have been made before 2010 and the work that you oversaw there in relation to some of the the kind of structural situations and policy choices that governments around the world are making and did make in those years, what was the trajectory of travel from a sort of policy choice that you were seeing countries make? And I'm interested to know, obviously you've taken us through the choices that were made under the Conservative government and the austerity in the UK, but have we seen that similarly replicated elsewhere?
Yeah, so I chaired the WHO Commission on Social Determinants of Health, and we reported in 2008. We said on the cover of our report, social injustice is killing on a grand scale, which was a bit challenging for member states of the World Health Organization, 194 member states, but they agreed to have a global conference. That was one of the recommendations that I made on social determinants of health. 120 member states were represented in Rio de Janeiro. You might say, well, of course, anybody would go to Rio, but 120 member states. There were something like 65 ministers of health there. So we got on the global agenda. Now, being on the agenda doesn't mean things will happen, but it's a step in the right direction of having people discuss these issues. Now, a lot of ministers of health interpreted social determinants of health as access to health care. And as I said at the beginning, access to health care is vital, but it wasn't what I was talking about, which was social determinants of health. But we did get take up. I remember once a BBC interviewer saying to me, "You're a professional optimist, aren't you?" And I said, well, look, there's 194 member states. And if 8 have taken up my challenge, I'm not going to go around the world and say 186 countries are ignoring me. I'm going to say there's 8 that are leading the charge. In a month's time, there could be 10. And after that, there might be 20. So countries like Costa Rica, Brazil initially, not at the moment under its current leadership, but Brazil partnered with us. The UK partnered, and I'll come back to the UK in a moment, but several countries partnered with us, Finland and the Nordic countries, and we saw action at national level. Sweden set up its own commission on social determinants of health, very similar to my review in England, with very similar conclusions. So we got a number of countries that took it on at a national level. England was a good example of what can happen at a sub-national level. So when I reported in 2010, the government changed, and although they welcomed it, they didn't do much. They had other priorities, which was austerity and cutting back the state, as I've just shown you. But Coventry became a Marmot city. Local authorities around the country got interested. We worked with Coventry. We're working with Greater Manchester. We're working with Chester and Merseyside. Gateshead put out a new strategy for the city based, they tell me, on Marmot principles. In Italy, the cities of Trieste and Bologna, they told me they were Marmot cities. I don't think anybody in those cities knew that. But so there was a lot of action at city level as well. And last Monday, the Inequalities in Health Alliance launched 77 healthcare organizations, 77, 20 of them, their name begins with British, 18 of them, their name begins with Royal, and another 12, their name begins with faculty. So these are not marginal organizations. These are important organizations that have committed themselves to health equity and action on social determinants of health. So your question is a good one, but it's not only national governments that we want to.
That's quite interesting, actually. I'd like to explore that a bit more because clearly during the Cameron government and the May and the sort of fallout from austerity was very much landed at the government store. I'm interested in what you would have to say is it possible for local government to take a different path and potentially kind of strike out on their own and challenge the inequalities despite the national government perhaps making their job harder? Is that something that you can actually do successfully?
It's harder. I mean, it's difficult for a city government to reduce child poverty. That depends on the Chancellor. And I didn't show you the graph, but it's in my report. And the Chancellor's policies, particularly in the middle of the decade from 2005 on, made poor people poorer by adjusting the tax and benefit system. It was an explicit policy. The lower the income for families with children, the more money they lost from these changes to the tax and benefit system. So it was a policy to increase child poverty. And it worked. It did increase child poverty. So then you ask, what can a city do? Well, they can't reduce child poverty. But the evaluation from Coventry suggested that there were improvements in early child development. There were more companies paying a living wage. They did reduce the number of young people that were NEET, not in employment, education, or training. So there are things that can happen at a city level. In my report, I had a box from Greater Manchester, which Andy Burnham was very pleased with. It showed that children eligible for free school meals in Manchester were doing worse on early child development than children nationally eligible for free school meals. And within 3 years, Greater Manchester closed that gap. And they closed the gap by focusing on services for young children. They couldn't reduce child poverty, but they could improve services. And one of the things that happened, many of your members will know, 1,000 Sure Start Children's Centres closed because of cuts to local government. Well, local government, it's difficult when you're facing 32% reduction in spending, or if you're in Liverpool, 40% reduction in spending. It's difficult to keep the Sure Start Children's Centres open, but you could make that a priority and make a difference. So yeah, there's quite a lot that can happen at city and regional level.
I wanted to, I'm naturally as a journalist, Sir Michael, I have to ask the odd pejorative question, and I'm just interested what you might say to people who might look at some of your comments and reports and say, well, he is making an excuse for people making poor personal choices. And I wondered if you could sort of take us through on why that sort of argument, which I've heard quite a lot actually in the realms of reporting your sort of work. And I wondered if you wanted to meet that one head on.
Yeah, I was giving evidence to a parliamentary group recently, and if I showed you a transcript of the conversation, it won't be difficult for you to pick which of the parties the person who said exactly what you've just said belonged to. I could function on a low budget. Those people don't know how to cook, and I tried it, etc. Well, the first thing to say is, so let's take food choices. I had in my report a graph from the Food Foundation that if you're in the bottom 10% of household income, to follow the healthy eating advice, you would have to spend 74% of household income on food. Now, you might, if you're still of the persuasion that it's their own fault, you might step back and say, well, what were they doing in poverty in the first place? It was their poor choices that led them into poverty. Okay, they can't afford good food if they're in poverty, but they should have made better choices. Well, we know that more than half of the households below the minimum income threshold, in other words, in poverty, more than half have at least one adult working. So they're in poverty, not because of poor choices, they're in poverty because of poor pay. So that's one response. Don't blame people for being lowly paid. Blame the system that doesn't pay them enough to be able to feed their children. A second response would be, and I said this to the politician who made the point that you've made, I said, my guess is if you gave advice on how to cook and how to feed your family on a low budget, the lower the household income, the less likely they would be to follow your advice. They may not have a separate kitchen. They may not have a separate dining room. 18% of people in England have at least one meal a day at a table. Only 18%. Now, in some cases, that's because people don't have a table. But what does that actually mean? And I said to this politician, if you're a single mother, depressed, in overcrowded accommodation, one antidepressant away from feeling suicidal, my guess is you wouldn't find it so easy to follow your advice on how to cook. So no, I think the evidence shows that people don't fall into poverty because of their poor choices. They make, quote unquote, poor choices because of their poverty. Solve the poverty problem and people will make better choices.
And one of the challenges, I think, to solving that problem is obviously the policy making choices that governments make and the choices that they bring into that, and perhaps they make some pretty poor choices. I think UVEX showed us some of the choices made by the Conservative government since 2010 could be classed as poor choices. I wonder about the reason for these choices that are made. Do you consider them to be ideologically driven, intentional choice? Was this the aim, or are the negative results that you're showing unintended consequences, and the politicians just didn't heed the advice of people like yourself?
Well, remember John Maynard Keynes' famous phrase, and I'll ruin it because I won't be able to quote it exactly, but that any politician that claims not to be ideology is usually following the ideology of some dead economist. So when you say, are they ideological? Of course our politicians are ideological. They're all ideological, whether they're left, center, right, extreme right, they're all ideological. And that's right, we all have an ideology. And I'm perfectly happy to debate people of good faith who are right of center, left of center, or whatever. I'm perfectly happy to debate people of good faith. I'm not happy to debate people of bad faith who are lying about the choices they're making or the reasons for the choices that they're making. Now, the Conservative government did lie about the state of the economy, and they knew they were lying. There was a global financial crisis, and they said it was because Labour overspent. And that was a dead straight lie, and they knew that. And they repeated that lie 3 times an hour, 14 hours a day, till it sort of became the truth. And it wasn't true. There was a global financial crisis. Labour's overspending didn't cause Germany's economy to go down and the US economy to go down and Canada's economy to go down. It just wasn't true. It was a lie. And they took that lie as an excuse to roll back the state. That was ideological. No question about it. And I saw my role, I see my role as not arguing a party political position. I see my role as arguing from the point of view of health and the fair distribution of health. I'm concerned that whichever party is in government takes the policies that will improve the health of the population and reduce health inequalities. That's my argument. And in fact, my 2010 review was commissioned by the Labour government, and then they were followed by Conservative-led coalition government. And when the senior Labour politicians were now in opposition, one or two of them said to me, we're going to use your report to beat the government round the head with, but you have to work with the current government. You can't sit on your hands for 5 years. You need to work with the government in power. And that's very important. And I'm perfectly prepared to, provided they don't take actions that will make things worse. And if they are pursuing policies that will make things worse, it's my responsibility to show it, which is what I did. Now, that can be interpreted as party political. That's not the intention. The intention is to show how you're damaging the health of the population. And they claimed to be doing it to improve the economy, to get the public finances right. Well, that didn't work. I have a graph in my report that showed that real wages between 2007 and 2018 went down in England. And the only countries that did worse than us were Mexico and Greece. Every other country did better than we did in terms of real wage growth. So they took a set of policies notionally to improve the economy. That didn't work because real wages didn't go up. And I think they did real damage.
Yeah. And I suppose the one challenge for governments in turning this situation around is the short political timescales that governments work to. And in fact, I wanted to ask you that we've seen in healthcare, particularly in the last few years, a sort of recognition that you need to plan for the longer term. And the NHS now has a quote unquote long-term plan, which seems to not be standing the test of time very well. But nevertheless, there has been that intention to make a sort of longer term strategic investment. And I just wonder, it's governments obviously work on an electoral cycle. How much of a risk is that to your wider agenda and the wider agenda that we all obviously need to work?
Well, what I've tried to do, it is a risk, of course. I've tried to do two things. One is have a policy of naivety, which is for me easy to be naive, political naive, but to encourage politicians to think well of themselves. You're here to improve the well-being of the people you serve, aren't you? What's your mission in politics? So think better of yourself and be a statesperson, a stateswoman or a statesman, and think for the longer term of how the population will benefit from your policies. Now, you may say, I'm hopelessly naive, but I'd rather be hopelessly naive than politically canny. Look where that gets people. And the second is to come up with a set of indicators that can show progress quite quickly. That, yes, in the longer term, reducing health inequalities, no government in the short term can show that they did that in the short term. That takes much longer. But a bit like the mayor of Greater Manchester being really quite pleased that they'd reduced the gap in early child development between the poor kids in Manchester and the poor kids in the rest of the country in only 3 years. They did it. So you get indicators that show progress much more quickly than that. So two prongs to it. Try and convince politicians that they're in there to improve the public good. So they've got to think more grandly and more strategically. And secondly, to come up with indicators that can show progress quite quickly.
And I'm conscious of time, Sir Michael, but obviously we need to talk about coronavirus. As much as everybody on the call would like perhaps never to hear that phrase, but unfortunately, it does seem to be a virus that is very adept at exposing and making the most of existing inequalities. Why do you think the virus is so perfect at exploiting those inequalities in society that we've seen?
I think the same reason that the tubercle bacillus is. I think the same reason that the Vibrio cholerae bacterium is. I think the same reason that pneumococcal pneumonia is. That people's disease, likelihood of getting disease relates to exposure, but it also relates to underlying vulnerabilities. We know with tuberculosis, TB, Russian literature would have been impossible the 19th century without TB. Where would Henry James have been without TB? And we know that overwhelmingly it infected poorer people, people with poor nutrition. It's really interesting. In the 19th century in the US, it was noted that African Americans had higher mortality from TB than whites. And it was really quite interesting that Southern doctors from the Southern US thought it was genetic, that Blacks were genetically susceptible to TB, and Northern doctors thought it was poverty. Well, when tuberculosis mortality went down, I don't think you get a research grant now to look at whether Blacks are genetically susceptible to TB, because improved nutrition, reduced poverty, and it goes down in both groups. So come back to your coronavirus question. We think that there are issues about exposure, and the ONS has been brilliant in publishing these analyses, that people in frontline occupations in the health and care system, drivers, people who are having to work in exposure to the public. ONS published some analyses showing public contact by occupation, and the higher the public contact, the higher the COVID mortality for that occupation. And then overcrowding. I was hearing about a nurse living in a one-bedroom house, a one-bedroom flat with 2 children. And she came home, and the first thing she wanted to, from work in the front line, the first thing she wanted to do was get her clothes off, get into the shower, and clean before she hugged her children. But that's pretty difficult if you're in a one-bedroom flat to try to stop infecting your family when you come home. And that's for a nurse who's we think of as a professional. She should be relatively well paid. Of course, she isn't, or he isn't. So I think it exposes the inequalities, both because of, as I said, the general social conditions that lead to inequalities in health, but with COVID-19, exposure is important. Interestingly, ONS's recent publication on pre-existing health conditions said that that was not the reason for the high mortality in Black British. It was much more to do with deprivation and geography.
So given where we are, we know that the virus is exploiting these existing inequalities, and we can see when we look at the heat maps for the virus at the moment that it's sadly following a very north-south divide at the moment, and particularly traveling, with great speed through some of the more deprived communities. Given your role in the last decade overseeing all of this, wanting to see improvements in people's health and inequalities, to see this virus ripping through the north of England and deprived communities and ethnic communities, I mean, how do you feel about that? And also, how worried are you for the consequences and longer term impact of this?
Well, I'm enormously worried. I mean, to come back to my phrase of exposing the underlying inequalities and amplifying them. And that's what we're seeing, amplifying them. With my colleagues, we're going to publish a report in December on the effect of the pandemic and the societal response to the pandemic on inequalities. So how the pandemic has affected what we said in February 2020. We're going to, in a sense, update that in the light of the pandemic. And it won't surprise you to know the news will be bad. It will. Let me take just one issue, the closure of schools. We, in my 2020 report, showed the social gradient in educational outcomes. The effect of school closure is utterly predictable. The evidence shows very clearly kids in independent schools, when the schools closed down at 9 o'clock, they had maths. At 10 o'clock, they had English. At 11 o'clock, they had history, etc. They had online learning, very structured, the lessons. They have somewhere to work at home. They have good broadband access. They have a computer to work on. And the schools structured it. Kids in local authority schools didn't have all those privileges. And the evidence is very clear. The gap between the better off kids and the poorer kids opened up. Now, that was a soluble gap. We could have done something about that. We could make sure that every child in the country has access to high-speed broadband and has some kind of low-cost computer to hang off the end of it. We could have made clear that teachers were expected to continue to conduct lessons online when the schools closed. We didn't do it. So it increased the inequalities. And I could go through all of my recommendations like that, and we'll see the same thing. So I'm terribly worried. Now, when at the 2019 election, the Prime Minister said he wanted to level up the North-South difference, I said, great. When I published my report in February, said if the Prime Minister is serious about leveling up, we've given you the evidence of what you need to do to level up. Now, pandemic then happened, but he's still got to do it. And to hear the mayors from across the north, not just Greater Manchester, to hear the Conservative politicians in the so-called Red Wall that collapsed, argue to a person that they've got to be serious about investing in the North. This shows how vital it is.
You mentioned school closures.
Sean, I'm going to have to cut in, Sean, and allow for some questions. Sorry that not to be able to give you any warning, but I didn't want to cut Michael off. I'm going to hand over to Jacob now, who's going to give us a selection of some of the questions that have come forward.
That's all right. Thank you, Danielle. And sorry to cut you off, Sean, on that. I'll try and summarise some of the questions together from the network. The first one, maybe if I give a couple of questions, and then Michael can take those and then come back if there's still time. So the first one was looking to the future and how the country will deal with the recovery from the pandemic, in particular the economic impact of it. So Michael, what do you think further austerity measures are likely, and what impact will that have? And if there were funds available to invest in improving health inequalities, what would your advice be to government and local authority? Where should they put that money? Where is it going to make the biggest difference? Is it in education, housing, welfare, social care, health services? Is there one particular area to invest in? And the final question I'll leave you with on this section is, local Healthwatch have strong links into their local communities, all different community groups, and also local decision makers in local councils and in health services. What questions should we be putting to those local leaders to progress the improvement in health equity in this country?
Well, thank you for those. Austerity. I thought it was really interesting that when lockdown happened in March, the government said, whatever it takes. Oh my gosh, this is the government. Well, it's not the same government, but it's the same party that in 2010 said, we have to impose austerity or we'll become like Greece. Now, that was flawed economic analysis. Again, it was either illiteracy, economic illiteracy, or it was something else, but it wasn't correct. And in 2020, 10 years later, it's saying whatever it takes. And the Prime Minister said, I don't want to hear the word austerity again. Now, you might ask, is that real? Yeah, it is real. I'm no economist, so I'm not declaring that I'm subscribing to the ideology of some dead economist. But as I understand it, when you've got zero interest rates, in fact, we're talking about potential negative interest rates, whatever that means. I think it means that if you invest in government bonds, that you get less money at the end of the 10-year maturity of the government bond than you put in at the beginning. So you're paying the government to look after your money. So where we've got negative interest rates and we control our own currency because we didn't join the euro, the government can spend whatever it likes. The Bank of England or the Federal Reserve in the US can print money. The government can spend whatever it likes. It doesn't have to worry about debt. It can worry about debt in the future, but when the economy's in the doldrums and it's not growing and interest rates are zero, the government can borrow. So you as a household, and again, this was another fundamental economic error, comparing the government to a household, you as a household can't print money. You can't borrow money ad libitum. You have to pay it back. The government doesn't have to pay it back in the short term. So there's absolutely no need to impose austerity when the economy's undergoing such severe shocks. So it can spend. So then the question is, where should it spend? And you made a list of possibilities, and my answer to that list was yes. Had I thought that there was only one priority, I wouldn't have laid out 6 domains of recommendations. I think we need to do all 6. We need to spend on early child development. We need to spend on education. I mean, up to 2020, between 2010 and 2019, the per capita, per pupil spend on education went down by 8%. That's terrible. What better use of money is there than to spend on education? And we reduced it. So we need to spend on education in a fair way. The third is thinking about employment and working conditions, and that very much we need to be thinking about the green economy as we emerge from the pandemic. The fourth was having enough money to live on. Every person in the country should have at least a living wage. That's possible to do. It can be done. The fifth was healthy and sustainable communities. And that leads into the other question, which I'm really delighted with. You said Healthwatch is closely linked to its local communities. At the meeting we had to launch the 2020 report, I said, I thought that I'd failed miserably in trying to get the message across to the population, to people. And somebody from the audience said, you're wrong. I'm working with local communities, and people understand the social determinants of health very well. So Healthwatch could play a vital role with close links to the community, that the 5 domains I've just talked about, and the 6th is getting prevention right, like healthy eating and so on, it can play a vital role in vitalizing communities. I mean, lots of people have pointed to the early stage of the pandemic of realizing the wonderful role that communities played. People came forward and knocked on the doors of older people and asked, do you need help with your shopping? Can I do anything for you? I mean, we realized how vital communities are, and the pandemic revealed that. We're now in a chaotic situation where we don't know whether we're coming or going. But certainly at the early stages, we realized what a vital role communities have to play. So yes, getting communities engaged on the Marmot 6 is absolutely vital.
Thank you. A couple more questions from the audience. So on that point about the sort of the volunteering and the difference that communities have made, do you think that we'll see a return to sort of conversations around big society and whether that will make a difference in this space? Sort of, I suppose, a question here that's not about the right or wrongs about health equity, because we would all agree on this group about investing to improve health equity. But in the long run, is it cheaper to invest in health equity than not, than to deal with the economic consequences? And finally, in terms of proven formulas, that you've seen elsewhere in the world that can get this right, is there anything that you would particularly suggest that Healthwatch encourage local and national leaders to look at?
Well, I never did much like the phrase big society. I mean, it was a confidence trick. Instead, I talk about empowerment of communities, empowerment of individuals, empowerment of communities, and empowerment of societies. We need to provide the conditions for individuals and communities to be empowered. You can't be empowered if your budget has been slashed. You can't be empowered if you can't afford to feed your children. I mean, I'm not enough of a football follower to know about his football skills, but I'm aware that Marcus Rashford did score a lot of goals recently, and he seems to be much prized for his football skills. But like everybody else in the country, I'm delighted to applaud his campaigning skills, whatever merits he has as a footballer. His merits as a citizen are outstanding, because he's drawn attention to families who can't afford to feed their children. Big society, that's not the solution. Having enough money to live on is the solution. And once people have enough money to feed their children, then they have some possibility to be empowered. Once communities have what they need to make sure that transport and roads and recreation facilities and parks and so on, that all takes money. But then we don't want government to do everything for us. We want communities and individuals to be able to do things for themselves. But the government has to provide the resources that allow that to happen. Now that's, I would like to think, a slightly better analytical approach than some slogan about, well, the government will stop funding everything and we hope people will make up the difference. And in that context, the third sector is of vital importance. The voluntary sector. is of vital importance because they're the best people. You know, they're people who are highly motivated to help because they think it's the right thing to do. Vital. That's all part of empowerment. And that's the way I would put it. And yeah, we do have good examples. I mean, to go back to Trieste, when they invited me to Trieste, they said, we're a Marmot city. Forget that. I learned much more from them than they learned from me. And similarly in Bologna, they have activity at the very micro level in the city. They have social care, education, healthcare, all working together at a very micro level to work with communities to improve things. And in Bologna, I was just inspired by this third sector organization that I visited that was working with refugees. And these inspiring young people, but they needed money. You can't say, oh, big society, we won't give them any money, let them figure it out. They needed money, but inspiring young people who are motivated by the highest ideals and good practical common sense, working with disadvantaged and needy people. So yeah, there are good examples of how you can get empowerment at the community level.
Well, thank you very much. I think that's all we have time for now in terms of questions. So first of all, I would just like to say thank you so much to Sir Michael and also to Sean for all of the campaigning work that you do on this really important issue and for sharing your knowledge and your time with us today. Obviously, as we go forward for the rest of the week, we will be reflecting on this conversation, which will set the tone for the rest of our discussions around the priorities of Healthwatch. And finally, thank you for all of the Healthwatch participants and for your contributions and for your questions today. It's really got us off to a good start for this Healthwatch week, so thank you. We are now going to take a 15-minute break and we will come back to the breakout sessions at 11:30. So thanks again, everybody.
And thank you, Sean.
Bye-bye. Bye-bye, Sean. Bye-bye, Sir Michael.